It's interesting because as an organisation, we're actually the biggest provider of healthcare in the North East. A lot of people will assume that that's Newcastle, one of the big tertiary centres, but we provide a huge amount of care. We've still got quite a lot of health and wellbeing services. As the chairman described in his opening introduction, we acquired community services back in 2011, and that gives us a fantastic opportunity that we've got to further exploit, to really knit care together, to integrate care with our acute hospital care. And we do have the facilities that we've already touched on at Bishop Auckland, providing that dedicated planned hospital care. Huge opportunity, huge geography. You probably all live in it, so you know some of the challenges that that also brings with it. I'm not going to go through all of these slides in detail, but over 2 million patient contacts each and every year by our staff, and you can see the various areas that they're in. It's really important to us that when we're working with staff, staff are what make the organisation what it is, that we can connect with them, that they can connect with patients, and that we can resolve, particularly in difficult times, around a common goal. So we use "with you all the way" to describe what we're trying to do with patients. This came from the staff, and it's our commitment to put patients at the centre of everything that we're doing. So you'll see this strapline in our annual report on all the various posters and things, and it really does connect with the staff that we have in the organisation. Because healthcare is complex in our planning, we're also trying to simplify things so that we don't lose sight of the goal that we're trying to achieve, and that we can simply judge how effectively we're getting there. So we have these touchstones. Again, if you get a chance to read the annual report, you'll see them. But we're striving to have the best clinical outcome, the best experience for patients, be the best employer so we can attract really great people to work in the organisation. And as you'll have gathered from Peter's presentation, we do have a requirement to continually look to become more efficient. In 2013-14, we just did so much. You've heard some of this already. I think that some of the improvements in staff survey, I would like to just pull out and illustrate. Mike referred to how important staff are to the organisation. International evidence also shows that the more satisfied and content and able to get on with their jobs that your staff are, the better clinical results that you will get. So we're putting an awful lot of focus into that. You can read the other areas for yourself, and you've seen some of those on the video. We did perform very well. Peter has described that we overperformed against our financial ambition. Monitor, our regulator, also review us in terms of some of the clinical ambition. They look at a little bit of a narrower set than that Mike described in the quality accounts. And you'll see from the table up there on the screen that with the exception of A&E 94.92 for the year against the 95% target, and the 62-day screening patients for cancer to first treatment at 87.9 against a target of 90%, we hit all of the targets that the regulator regulates us on, and they actually gave us a green. They've got a simple RAG rating, red, amber, green rating for governance, so we got the top categorisation from them. When things are difficult, and when the environment, as we all hear in the press, is more difficult than it's been perhaps in the NHS before, it's even more critical that we're able to look forward and develop our services. So it's critical that we manage to ensure that we can use the financial resource within the organisation to best effect. And as has already been described, we've put in digital records. That makes a huge difference to the accessibility of critical clinical information for clinicians when they're dealing with patients. You saw Phil Davey, one of our vascular surgeons there, describing to you what a difference the new vascular theatre at Durham has made to him, his staff, and critically his patients. We've got the new research centre. You saw pictures of Darlington Memorial's outpatient service, completely revamped, dementia-friendly, really making a difference to patients that are attending it. We've recently extended our bowel screening at Bishop Auckland. That's a really critical extension to the national screening programme, and we were one of the first to be able to exploit that locally for our population, for you and us. We've got ambition around the education centre, which we are developing this year at Durham. We have put in place new services to help support patients. You saw the ISIS service being described by Wendy Lyons, one of our clinical staff. We have a coordination centre for the first time that we opened at Christmas, which means that our clinical staff, when they're looking to discharge patients, have a one-stop shop to help them ensure that that discharge is timely and that all the services that are required for the patient are put in place. We've got a new gynae day unit at Chester Street. It's fantastic for ladies. They can come and have services done as day cases that years ago they would have been in hospital for a long time around. It's a very discreet, nice, purpose-built facility, and it's helping us use our estate. And Chester Street, as some of you will know, is one of our PFI services, so it's critical we make best use of all of the space. And we've recently, back in February, appointed a Chief of Staff for Elderly Medicine, David Bruce. If I were to show you the demographic, the patients that we serve, a lot of the patients that we serve are in the more elderly bracket, and therefore our elderly services are going to be critical going forward. We know if we look forward 10 years, we've got a big increase in patients or the population who are going to be more elderly with more complex comorbidities, and we also have a smaller expansion of children, and the shrinking bit in our population is going to be everybody in the middle. So it's absolutely fundamental that we have the leadership that we need to make sure that the elderly services are fit for purpose given that demographic, and David is admirably leading that for us. We are hospital and a set of community services and health and wellbeing services, but we also have a huge responsibility to our communities. Some of the biggest determinants of health in a population aren't what are the health services that are provided, but they actually revolve around what are the employment opportunities, what are the educational opportunities, what is housing like for that population. So we take our wider responsibility very seriously, and we try and secure as much of the procurement, as many of the things that we buy, we try to buy locally so that we're helping the local economies, that we're generating jobs within the local economies, whether that's within our organisation or when we're buying, for example, our catering supplies, we try and use local farmers and know that that job creation is going to have a really beneficial impact on health. We're one of the largest employers, and we have, as a patch and within the North East, some significant unemployment, and particularly among the under 24s. So we're very active in looking at apprentice schemes so that we can bring people who haven't had the educational opportunities that some have had into a career that we hope with us will last them a lifetime. It's critical that we can capitalise on those. We work closely with the voluntary service on all sorts of different schemes, and recently in last financial year we introduced lunch clubs so that we provide lunches so that in connection with age concern we can provide food for the population, the well population, and actually a facility for them to get together. That social interaction is massively important to keep them healthy and well, both physically and mentally. And we have a responsibility in terms of our carbon reduction target, and our team have just done fabulously on this. Bill Headley, our Estates and Facilities Director, is sitting on the second row there, and that, I think you'd agree, they've performed huge amount of work and given us a 16% reduction on our carbon footprint against a target of 10%, so very well on them. As we look forward, Peter has described quite clearly that there are very difficult financial times ahead. It really doesn't seem to be more than a day that goes past before some organisation gives us a very bleak look forward. Most recently it was the King's Fund who have identified that their belief is that whoever after the election is responsible for delivering healthcare will pick up a very broken system. And it's very difficult in those with all of that news and in all of those times to make sure that we don't get distracted by that, because life is hard. It's hard for our staff. It's critical that we can continue to make progress, that we can continue to make improvements such as those that Mike's described in terms of some of the quality indicators. So we need to give very clear direction to our staff. We need to work with our staff to involve them in agreeing with us that direction, and therefore strategy is never more important than in these choppy waters. And we have been working on our strategy, and I'll share some of the key components of that with you. So it's our evolving clinical and quality strategy, and it's at the heart of what we're trying to achieve as an organisation. Just yesterday, Monitor contacted me, and they have been reviewing, as has been described already, both our 2- and 5-year plans. And they've actually asked, can they use some of the work that we've done with our clinicians, with our patients in developing those plans as best practice in a publication that they're intending to issue later on in this year. And I think that's a bit of a hallmark for just how much effort our clinical teams have put into this. And I would pay credit to Chris Gray, who's sitting just next to Mike up there, because Chris has very much been leading on the clinical strategy for us as an organisation. So what we have at the heart of this is getting care right first time 24/7. So our vision is it's the right person that sees the patient in the right place at the right time, that we get that right first time, and we do that 24/7. We've agreed principles in terms of how we establish that in practice with our clinical teams, and I'll let you just read those out as I move us to the next slide. I think critical is ensuring that in a market where we're finding it more difficult to attract staff and there are less medical training staff available, and we want to get the right person first time, we are moving towards a more consultant-delivered model, and our physicians and A&E docs have some of the longest coverage per day in the whole north of the northeast in terms of the times that our consultants are available to see the patients that present into our 2 main hospitals. At the same time, it's critical where we can, where it's safe, effective and efficient, that we do get patients dealt with as close to home as possible. And as I've already described, older person is at the heart of our service delivery, particularly given our demographic. Mike has already reminded us that quality means something that we can break down. We can break it down into safety, experience and effectiveness. And Mike has taken you through some of our achievements in 13-14 and ambition for the year that we've just begun. The critical things we're describing in this year are our breakthrough schemes. So there's 3 of them. Transforming unscheduled care is the first. And some of you may be aware that not Monday gone, but the Monday before, for example, we opened up a clinical decisions unit, a surgical clinical decisions unit at Durham for the first time. On the video, you saw one of our members of staff, Ian Ridley, telling you about how successful that's been in Darlington. So we've rolled that out into Durham. And on Monday coming, we've got a big move at Durham, which essentially allows us to provide more medical beds for that bigger cohort of patients, but also allows us a bigger assessment area so patients can be assessed by consultant staff more quickly, and if it's not necessary to admit them, they can not be admitted but be cared for closer to home. It's really the beginning of a massive journey that we're on. We will be focusing on unscheduled care, not just in this year, but for many years to come, because it's such a fundamental part of the care that we're obliged and privileged to provide. In terms of the integrated care, the chairman described in his opening remarks that we have made some strides towards better integrating care, but we can see and we know from staff that there are more opportunities to do that better. So we're working on how we coordinate care so that for patients, for their families and for staff, transitions of care between different parts of our services are smoother, that we don't have to repeat tests, that patients don't, for example, have to give their information out 5 times and can do that once, and that we get that better, and we're working closely on it. The ISIS work is the biggest example of that, and as well as the Care Coordination Centre, we're working more in multidisciplinary teams so that care is brought around the patient and the patient doesn't have to hop between different bits of service. And finally, and this has been touched on again, centres of excellence. So where technology dictates that actually there are better ways, more effective ways to deliver things, how do we do that excellently? How do we focus on those services and ensure that if we are able to provide a service such as stroke that has demonstrably improved the clinical outcome by making some change to it, that we do that, and we do that with the patients. And there's just a couple of examples on the slide to give you a flavour of what we're looking at during the course of this year. We have agreed these plans with our senior clinical team, and some of the changes that I've just described, particularly at Durham, are on the screen in front of you. I won't go through them again. Also critically at DMH, Darlington, you've heard a lot about what's already happened there. The STEM business case is the theatre case, so as well as looking to develop our theatres at Darlington, we also would like to set up a bereavement centre. We don't currently have one, and improve the mortuary facilities, so that's something the board's actively working on. We use a very simple model when we're developing our plan, and this is what Monitor's latched onto, and it's what it wants to use as best practice. So for each clinical service we provide, we look at how clinically sustainable is it now and moving forward, how operationally sustainable is it, i.e. how effectively can we manage to keep that service running with the human resource, the finance, etc., that is required to both now and casting forward 5 years, and what is the financial sustainability of the service given the financial outlook that Peter's described. And then we plan each of those services plans using that as a core aspect of their model. In doing that, there are areas that we've identified where if you look forward 5 years, there will need to be some change. And again, I won't go through those, but you can see the areas that we're looking at. And so for different aspects of that three-circle model, these services are being worked through. And then we also, alongside all of that, managed to put in a huge amount of innovation, and some of the work that our clinical teams come up with, along with all this longer term planning, are developing improvements that actually are winning awards. So we've got our health call under nutrition team here. Rachel Masters was out in the display area earlier, so hopefully some of you got to try her fortified drinks and the juices that are making a real difference to hydration and nutrition of patients on our site, but also have wider application in terms of other services right across the NHS. We've been granted a Better Health at Work award, and that's critical because we want to have the best cared for workforce, so it's really important work, and we were very pleased to have that awarded to Janet Sedgwick on behalf of the organisation. And we have and would extend congratulations in the end of life category to a prison project. And I picked this one out because it shows the amount of work that we do in conjunction with other organisations, because partnership and collaboration is going to be a hallmark of success going forwards. Each year we have our annual Trust Staff Awards. They're usually just into the new year, so it's always very remarkable really how many of our staff manage to attain qualifications, and usually, you know, the amount of first-class honours degrees absolutely makes me feel inadequate, because our staff hold down jobs and do all of this academic work alongside it, and then we celebrate a lot of the clinical achievements that teams have made and the improvements that people have made to healthcare. So they're always a really nice point, and it's important, particularly in very difficult times, that we celebrate success for staff. And I would just like to echo a thanks to our patients. We're very grateful for feedback that we get from them, their families, friends, carers, our staff, our colleagues, the partners that we work with, volunteers, hospital friends, governors, members of the public, the people that make donations to our charitable funds. We just couldn't be the trust that we are without them. And for being with us all the way in 13-14, we are really, really grateful. At this point, I just want to reflect on something, because life can be difficult for staff, as I've described, and the environment isn't the easiest at the moment, and we do have some challenges. But I do believe that the staff that we've got will rise to that challenge, and that they will help us be as successful as we can be through this year. things are difficult for them, and some of you will have seen in the news last week that there was an announcement about this organisation making up to 350 redundancies. I just want to clarify that for you as the audience, because that story was predicated on a requirement that we have as an organisation if we believe that there is a potential to make redundancies, and we think that there is a potential for there to be more than 20 compulsory redundancies. We're required to complete a document, and that story ran off the back of that document, which we completed in August. It's critical that we and our staff understand why we completed the document, what was behind it, and there are really three things driving this. One is that some of our commissioners are looking to provide services that are a little different. So we have staff particularly in health and wellbeing services, and they are being recontracted for this year, and local authorities are choosing different models, which means that the staff can't move across to these new models because there's already staff working in areas who are picking up this extra work. So essentially, for any of you that know the word TUPE does not apply. So unfortunately, as services are decommissioned, the reality for us is that there will be a level of compulsory redundancy. We're committed with a whole host of schemes to make sure that those redundancies are as limited as possible, but it is an inevitable reality, and it's just important that I share that. One of the other reasons that services can result in redundancies, and we're obliged to declare that they might, is when a service is re-tendered. So it's the same service, but it's re-tendered, and it might be a different provider. And sometimes not all of our staff map on exactly to a service. They might provide some of their work might be provided under a particular service agreement and some under another. So again, although the service model's not really changing, TUPE cannot apply. And as Peter's outlined, the third reason is that we do need to make some level of efficiency. We will not, as he has underlined, compromise on clinical care. And there is a rigorous process that the Director of Nursing leads internally to ensure that, and it's actually overseen by our commissioners as well, so there's no danger of us falling into that trap. But there are reviews that we need to do to capitalise on new technology and make more efficiencies. And so we're currently reviewing the administrative function within the organisation and looking at how that, with technology such as the remote access and working, might mean that we have a different model going forward. So I didn't want to leave this evening, given the difficult context that we've outlined, without making reference to that important point. But we are supporting staff as much as we're able to. We're looking to seek to protect staff by using holding vacancies, using agency staff, but there is an inevitability that there will, in the course of this year, be a number of redundancies. We hope it's nothing like the maximum number that was reported in the press. Thank you very much.